So again, this is a patient whose MRN and name on the images is fictional. It's produced by the system as an alias. So this patient has a history of metastatic renal cancer. This exam was from 2015, and they had some pulmonary metastases. On this occasion, that's just an inflammatory process in the right lower lobe that went away subsequently. By this time, this 2015 exam, some of the metastases that were like in the lung and then there was in the liver were already improving. But I just grabbed this one to show you that there wasn't any ascites. So the patient, and they had their nephrectomy already. And then this surgical procedure in the spine was done with corporectomy and posterior fusion at a site of metastatic disease to the spine. So really what I'm showing this case for is what subsequently happened. And it's really in the last two cases, you can see it very subtly on this more recent one. The annotations there, just looking at some of the liver lesions again, but you can sort of see very subtly here, kind of a fluid level in the ascites. So the patient ended up developing ascites. And because there's not gross peritoneal disease, even though this patient has metastatic disease, it's not clear exactly if it's a malignant ascites or a non-malignant ascites, but there is this subtle fluid level. It was missed on this occasion. That was December 2018, but it became considerably more obvious on this one here, which is more recent. This is May 2019. So you see this fluid level, and it's this attenuation with sort of fluid attenuation below it.
Does that mean it's like lymphatic fluid,
yeah.
like chylous fluid?
Yes. So this is chylous ascites, which has been described after retroperitoneal lymph node dissections and nephrectomies. And the only thing that's curious about this case to me is that the patient's nephrectomy was in 2002, I think. And here we are 2019, and now we have this ascites and with chylous ascites. Subsequent to this exam, because of the discomfort the patient was having, they did do a paracentesis on the ascites, and it did show sort of white milky fluid and a very high triglyceride content consistent with the chylous ascites. But it's not exactly clear to me, at least, and I don't really see anything in the literature to say why there was such a latency period between what I think is probably behind this, which is the nephrectomy. I couldn't associate. They also had some RT to the lumbar spine. I don't know that that's been associated with chylous ascites. And I think the patient's probably going to end up with intermittent paracenteses. These can be treated by dietary manipulation and maybe some drugs to try to reduce the accumulation of chylous ascites, and then occasionally interventions occur. I'm not an interventionist. I think I read that you could do some sort of venous shunting of the ascites. Do you know about that, RT?
Well, I was going to say that, like, maybe with the delay thing, I do like the radiation theory in that the radiation might have affected the cisterna chyli.
Yeah.
And so that's why you're getting all this backup of the lymph. It seems like that's a pretty dramatic ascites. So it feels like the cisterna chyli must be obliterated somehow. Right. And we've had some cases where patients, like if you have, actually, like the case you showed of the lymphangiectasia,
yes.
Those patients can also get chylous ascites. So we had one patient who was coming back weekly to get their chylous ascites resorbed. So one of the treatments IR can try to do is to try to recannulate the cisterna chyli if you think it's from the cisterna chyli. Not in the case of lymphangiectasia, but you can try to recannulate that. But otherwise, usually it's if you have a chylous effusion in your lung, they'll go through the cisterna chyli up to the thoracic duct and sclerose off the thoracic duct. So I don't know. I don't think there's great treatment for this.
Right.